Hi, I'm Dr. Simon Parsons, Dental Legal Consultant at Dental Protection. Welcome to RiskBites, a series of podcasts created specifically for dental practitioners here in Australia. RiskBites looks at the key dental legal risks and issues affecting dental practitioners across Australia and provides helpful advice and guidance on how to steer clear of them, leaving you free to provide safe and high-quality dental care for your patients. Today, I'm talking with Dr. Colm Harney, colleague and fellow dental legal consultant. Colm, I know that you've done a recent RiskBites podcast on cosmetic dentistry released earlier this year. At the time of that release, you told us that our regulator, Ahpra, had undertaken a consultation period focused around developing new resources for registered practitioners who were undertaking and advertising non-surgical cosmetic procedures.
Yeah, Simon, I did. And I would refer our listeners back to that episode where I stepped through a fictitious scenario with a new patient attending a practice requesting cosmetic treatment. In that scenario, I brought together many of the yellow flags, red flags, pinch points and pitfalls that we commonly see when we at DPL review these types of cases in our day-to-day work. I advised of the public consultation period, and then we were all left hanging by the regulator as to when these new documents would actually be released.
Yeah, we were, weren't we? And I'm guessing, because we're doing this podcast right now, that the big reveal has been announced. Is that right?
Yes, Simon. Okay. So Ahpra released a news piece on the 3rd of June this year, 2025, titled Booming Billion-Dollar Cosmetic Industry on Notice with New Cosmetic Procedure Guidelines. And within that document, it published advanced copies of the guidelines relating to performance of non-cosmetic surgical procedures and advertising of high-risk non-surgical cosmetic procedures, a copy of which I'm holding in my hands now to reference. So it stated that the guidelines would come into effect on the 2nd of September 2025. So of significance to me was, I think, the quite deliberate wording in the title of that news piece. The regulator is putting registered practitioners on notice. I believe that the intent signalled is for there to be greater oversight and scrutiny of this area of practice from September 2nd.
Yeah, I think so too. And I guess it raises the question then, what is it that we need to know and how is it going to affect us across Australia?
Yeah. So for simplicity, what I propose to do is step through the key points of interest in linear order of appearance in the document so that if you have a copy of the document to hand or on a screen in front of you, it will be much easier to follow. I'd also like to say that I'm going to signpost one large issue that I have with this document, but I'll deal with that later and I'd be very interested to hear your thoughts too.
Well, I know that we've all been poring over these documents in the office in between phone calls that we get from our members. Yeah. And I know that it starts with a definition. And I think that's always a good place to start. Do you agree?
Yeah, I agree. Yeah. And I think it's, as logical clinicians, a definition's a good place. So the definition given here is that non-surgical cosmetic procedures are procedures undertaken to revise or change the appearance, colour, texture, structure or position of bodily features with the dominant purpose of achieving what the person perceives to be a more desirable appearance. So relevant to dentistry, it gives a broad example of altering body tissue, for example, teeth. Excluded from the guidelines are procedures that have a clinical justification, and the examples given include, but are not limited to, the removal of skin tags and skin cancers and treatment for severe acne. So a good example in the dental context of what might be captured in the guidance is anything elective, driven by a patient desire to improve appearance. And an example of what would be excluded is a clinically indicated correction of a malocclusion or misaligned dentition that could be causing biological or functional adverse side effects for the patient, such as occlusal issues or inability to properly clean, predisposing them to caries or periodontal disease.
And the document then steps us through how the boards will use the guidelines, emphasising the overarching functions of the boards to protect the public and maintain standards.
Yeah,
Yeah.
it does. And now's a good point to state actually where my big problem with this document lies. It reads to me as a very one-eyed document pointing at practitioners carrying out cosmetic injectables. And my concern is that many practitioners who don't do injectables would glance at it and say, nothing to see here for me. So I think we need to park this regrettable overemphasis in the document to one side and bring it back to the broader, overarching definition that I mentioned earlier and understand that it captures much more than just injectables.
Yeah, I agree. And I think unless we understand the real scope and definition and get the fundamentals right, then we're going to misinterpret everything that's in here and whether we really even need to read it.
Yes,
Yeah.
exactly. Yeah. So point one in the document, just stepping through, is recognizing potential conflicts of interest. And this crosses over into the new advertising guidelines. So I'm going to reference back to your podcast on those guidelines, which will fill us in on that aspect.
Well, I don't know what you think about this, Colm, but I think the advertising guidelines are written more for all aspects of non-surgical cosmetic procedures, and it's much easier to overlay that document to broader clinical dental practice.
Yeah, I thought that too, and I urge members to review that document and listen to your podcast. I think there is as much, if not more, potential for dental practitioners to trip up on the advertising guidelines than these cosmetic guidelines. Anyway, I digress, Simon. Point two is an area that I think is going to create some consternation and questions. The assessment of patient suitability, noting that the practitioner should consider the person's history, relevant psychological, social and cultural aspects, and in particular assess for any condition which may make them an unsuitable candidate for the procedure. Now here it gives an example of assessing for BDD, which is something many practitioners may not actually even be aware of. So BDD standing for, as we know, body dysmorphic disorder. And I'd love to hear what you think about that, Simon. And my initial thoughts are that there are many practitioners covered by these guidelines, such as dental practitioners, nurses, even Chinese medicine practitioners who might be scratching their heads and saying, it's not within our scope to do psychological assessments of our patients or diagnose BDD. And yeah, while I would undoubtedly agree with this, many of the cases that we review in this space do show similar patterns time and time again. It's that old expression, history doesn't repeat itself, but it certainly rhymes. So I think what we can do more broadly is look out for those signs of unrealistic expectations, obsessive behavior, clues in the previous dental or medical history, and overlaying this being the old DPL adage or mantra, never treat a stranger.
Yeah, that's a really interesting point that you make, I think, Colin, because you and I have been around practicing dentistry for a long time now. And I think most of our colleagues who have been doing this for more than a few years would have my next comment resonate with them. And that is that when you first meet a patient, they're summing you up, but you're summing them up as well. And if you get that vibe about them that suggests, hey, something a little bit not quite right with this person or whatever, I've got to be a bit on my guard here. I don't think I need to better diagnose whether they've got body dysmorphic disorder or not, nor am I qualified to do so. But I think I've experienced enough, as you are, to know that a patient could pose us a dental-legal and clinical risk if we go ahead and treat them and do anything major. So I can understand where they're coming from here, but I think that it's probably confusing the issue a bit, isn't it?
It
in
is
one
a
sense,
little bit,
because irrespective of what their diagnosis is this patient going to be someone who's going to cause us potential heartache, a lot of sleepless nights, if they're unhappy with what we do for them?
So look out for the flags, take your time, maybe get to know them better, maybe do a checkup, a few cleans, put them on recall, see how they go with all of that. Don't rush in if any of those flags are waving. I think that adage, never treat a stranger, I think, as I said, overlays everything.
Yeah, and that way you can bail out if you need to.
Or refer.
And everyone's still happy because you're not committed.
Yes.
Whereas otherwise, once the handpieces hit the tooth
Yep.
or the jaw or whatever it is, once whatever you start, you need to finish.
Yes.
So, isn't it so true? I really like your point that you really need to get to know your patient, understand their habits, their likes and their dislikes, the sort of nuances that make that particular person who they are.
Mm-hmm. Yeah.
And if you do that before embarking on anything major, then it's a real sort of security blanket for them and for us.
Yeah.
Because hopefully they feel confident that you're the right person to treat them, but you also can feel confident about whether you're the right person to treat them.
Yes.
And so if you're both on the same page, then
It's
if all goes well, it will go very well.
Yeah,
but
it's a good starting point.
it is.
Yeah,
But,
yeah.
you and I see this all the time. And I know we're digressing here, so forgive me, but we see it all the time where the clinician hasn't really done anything wrong in the treatment of a patient from a clinical or technical perspective.
Yes.
But so often the patient is unhappy.
Yeah.
And it's all those unrealistic expectations, and it's the sort of strange ideas that they have about what they apparently thought they were going to get.
Yep.
Yeah. So that's really interesting. Thank you.
So the next point relates to cosmetic injectables and should be self-explanatory for practitioners carrying out those procedures. Point 4 relates to patients under 18. And again, I just refer people to the document. It's quite self-explanatory, but it is quite prescriptive, and so it is important to read if you are treating patients in that age group. Point 5 deals with consent. And this is an area where we, as you know, Simon, have a significant amount of resources to point our members towards, such as a website, podcasts, literature, as well as our online learning platform, PRISM, all of which is verifiable CPD. So I'm not going to go into this in great detail other than to say, again, it's also quite prescriptive, and it emphasizes the practitioner's responsibility to ensure an informed decision can be made, and it describes the need for a verbal consent discussion as well as a written information being provided in plain language to the patient.
Yeah, that's really interesting on a whole lot of levels, because I know we have these conversations all the time with our members, and it's one that I think the crux of it tends to be the simple question, do I need a written consent form? Is that sort of mandatory or like the standard of care in a sense?
Yeah.
Now, from what you've just said, it looks like for these procedures, some sort of written information does need to be provided.
Yeah.
Right?
Yeah, it does seem quite clear from the document, and I would suggest it's a good time for practitioners now to review their consent processes and maybe start drawing up some documents if they haven't already got them. As we know, in the document, part of the consent section also covers consent for use of images. Again, a question we often get asked on the phone lines at Dental Protection, and we see appearing on internet forums from time to time as well. So I refer our members to the document on this, as there are 7 subsections related to this use of images. So it's quite defined and prescriptive again. So it's important for members to review it and follow it if they do use images, patient images in any form of whatever way it's used. The next point, point 6, relates to prescribing and administering Schedule 4 cosmetic injectables. So again, only relevant for practitioners carrying out those procedures, and I urge them to refer to the document.
Okay. So what about the patients themselves? What do we need to know for all of that?
Yeah, so it's a good question, and the next few sections flow into that area. So sections 7 and 8 cover management of the patient and the right of the patient to make a complaint. Some of the information around the management of the patient, again, relates only to cosmetic injectables. However, it does move on to outline that there must be protocols in place for managing complications and emergencies. Written post-operative instructions must be given, and the health records must be compliant with the board standard. The section on complaints, again, is also quite prescriptive. Of note, it advises that the registered practitioner must ensure all patients receiving cosmetic procedures are provided with information about the range of complaint mechanisms available to them, including local measures and how to make contact with the clinic, along with providing information about relevant complaint bodies such as Ahpra. So any complaint resolution agreement must not contain conditions that removes the patient's statutory right to make a complaint to the regulator.
So that's not really new in one sense, but
No.
it's not very well understood, is it?
No, it's not very well understood, not very well out there in the public domain, but it is now.
Yeah.
Yeah.
Okay.
Yeah. So, yeah, as you said, it's not very much out there. It is now. And the only additional aspect that I think is going to be interesting is the expectation that the patient is proactively provided with information on how to make a complaint prior to the procedure. So I'm saying watch this space, and I'm waiting to see this one tested in front of the regulator. The latter sections relate to aspects of care that all practitioners following the Code of Conduct will already be compliant with, such as scope of practice, use of titles, working in appropriate facilities, and infection control. Again, it's very broad, a lot to go into, but certainly worth referencing the document to find out more if you're interested. Towards the end, the document also references advertising and marketing, which is covered more comprehensively again in the new advertising guidelines. So I will defer to your podcast and the webinar we're planning to release on that subject.
Well, thanks, Colm. That's really good to know. And your overview has really helped to inform us, I guess, of where some of the pitfalls might be and where we need to rethink our processes and how we manage our patients. I know you'll be providing the appropriate references and links in the show notes down that accompany this, so that'll be really helpful. If I was to get you to summarise then what our members really should try to be taking away from all of this when they go into practice tomorrow, what would that be?
Yeah. So before I make any suggestions about that, I think it's important to re-emphasise that Ahpra is sending strong signals here that this is an area of practice that's going to come under increased scrutiny. So therefore, practitioners working in this space should move to doing a deep dive into these documents if this is an area that they work in or emphasise, and remembering that definition as well and how much it actually covers. So as well as links to the documents you mentioned, Ahpra have also provided a quick guide about the document, and again, we will provide that, which outlines in one page quick outline of do's and don'ts. So in summary, key takeaways. Practitioners need to review and update protocols and internal documents on screening, assessment, consent, and cooling off. Practitioners need to understand scope of practice, appropriate use of qualifications and titles, and compliance with drug regulations where appropriate. They need to ensure everyone understands their responsibilities for post-operative care and that robust complaint management policies are in place. That's all good practice and common sense for most practitioners anyway. And lastly, consult the advertising guidelines and the DPL resources on this also, because they go hand in hand.
Well, thanks, Colm. That's been really helpful because certainly for me, it makes me contemplate, do I need to do more? I think I do. I think I've got to lift my game because some of these procedures, you don't really know when you get a patient coming into your chair whether there's a strong clinical justification for an intervention that could be a cosmetic procedure or whether it's really driven fundamentally by an aesthetic consideration until you start to deal with them. I guess you need to have all your procedures and documentation organised so that have all your ducks in a row here so that depending upon what the case is actually going to involve, you are compliant.
Yes.
Yeah.
Yeah.
All right. Well, thank you so much, Colm, and thank you to all of you out there for listening. We do hope that this podcast was helpful and we look forward to sharing more guidance with you in the future. And if you do like Dental Protection Podcast and would like to hear more, please subscribe and leave us a review.